In sepsis or a patient who presents with fever, you might have a SIM man. The SIM man is presenting with fever, all right? When you assess the patient, you find that he has sepsis. How to know that it's sepsis? From the sepsis criteria, okay? So you start by greeting the patient. Hello, Mr. X or Mrs. X. I'm here to help. Can you tell me what's your name? Confirm the identity and confirm the date of birth or the age. And then if you have notes on the trolley beside the patient, you can have a look, but the patient is talking, then you can just talk to the patient, all right? Have a look quickly at the monitor, please, doctors, to find out what are you dealing with, all right? The patient might be unwell, might be confused, might be short of breath. Whatever you see, you deal with it. Okay, the patient is short of breath, you ask him, are you comfortable to talk or not? If he's not comfortable, look at the monitor. If the oxygen saturation is low and the patient is short of breath, ask the patient to open his mouth and check if there is any tongue or lip edema. If no, then ask him, do you have any lung conditions or medical conditions? No, doctor. Then you can give him oxygen, high flow oxygen. Okay? This is how to deal if the patient is short of breath with low oxygen. All right? If the patient is okay, talking, not short of breath, then you ask the patient what happened. This is the mnemonic for Simman, Wabam. Wabam, then ABCD. What happened? I have fever, doctor. Then explain the fever. Since when you have fever? Did you measure it? Have you had any fits? Okay, fever, fits. All right. Then any specific thing happened before this fever? Then you take the patient systemic review from up downwards. Do you have any headache, any chest symptoms like shortness of breath or cough, any diarrhea or vomiting, any burning while passing urine, any wound in your skin, all right? To find out what is the source of this fever, all right? Quickly, then you can ask the patient, have you had any fever before? Or you can just move on to ask A. What is A? Any allergies? Any allergies at all? Any medical conditions or medication if you didn't ask from the start when the patient was short of breath. Okay? Wabam. What happened? Did it happen before? Any allergies, any medical conditions and lung conditions? Okay? Then you move on to the ABCD assessment. A, B, C, D, E. Okay? The patient is talking. So the patient, the airway is patent. Okay? You just give the patient oxygen if the oxygen saturation is low. If you didn't give oxygen from the start. Okay? It depends on the steps that you've done. All right? You give the patient high flow oxygen, 15 liters per minute, by a non-rebreather mask. Look at the monitor. The oxygen saturation is going up. Then, okay, move on. Okay? In breathing, I'll have a look, tap, touch, feel, and listen to your chest, Mr. X. Would that be okay? Yes. Inspect, palpate, auscultate, and percuss. And then if there is any abnormality, crepitation, or any signs of wheezing or anything abnormal in the chest, ask for ABG and ask for chest X-ray. You investigate as you go. All right? Then nothing, just the patient has crepitation. You asked for X-ray and then you asked ABG. You move on to C. I'll have you take the patient from central to peripheral. Okay? Heart sounds, blood pressure, pulse, and cap refill. Okay? We have talked how to explain these to the patient. All right? I'm not going to dwell on them. then you insert 2 wide bore cannulas to the patient, take bloods. What are you going to ask for? Full blood count, CRP, ESR, lactate, electrolytes, and kidney and liver function tests and clotting profile. Okay, these are the bloods that you need to take in sepsis. If the examiner asks you, okay, then ask for ECG in any scene, okay, heart tracing, and then based on the blood pressure, if the blood pressure is low, then you give you start by 500 or 1000 ml fluids over 15 minutes, okay, and you insert the catheter, cannula and catheter, all right. D, the patient is alert, talking to you, check the glucose, I'll check your blood sugar, I'll shine some light in your eyes, okay, check the pupils, and if the patient has any drug chart on the trolley, check them if they are present, okay. In this case, the patient is just coming to the hospital, to the A&E, all right. Dr. Ala, you told me I'll check the notes from the care home. Is it written in the question?
No, but it's part of the history. I know that.
No,
Because
Kero, if the patient is not on, if it's not mentioned in the question that the patient is in the care home, you don't assume things.
she is from the nursing home. She came from the nursing home in the
Are you
question, yeah.
sure? Is it written in the question?
I saw that. I don't know. I'm not sure. Can you please display that again?
Don't think that this
Nursing called you. Oh,
nurse
nurse.
has
Okay.
called you. Okay,
Okay.
all right. So read your question carefully. Yeah, all right.
Okay, thank you.
Yeah.
Okay. Thank
Okay. And in the exposure, you check the temperature of the patient. Here, the patient doesn't have any problem other than the chest. You can just say, you'll check the abdomen and legs if there is any wound, and that's it. Okay? If there is any wound infected, take a swab. This is if there is, and then please give paracetamol. I'm not sure if, I missed telling you doctors, please, once you suspect sepsis, IV antibiotics, Tazocin, all right? Okay? And give paracetamol for fever, all right?
And
In the
Mr.
management, can I just complete the management and then I'll answer your questions? Yeah. Then you tell the patient it seems that you have something called sepsis, which is spreading of infection to your organs. You have chest infection. Most probably this chest infection spread it to the organs. It's quite serious condition, but don't worry, we are going to treat that. Do you have any concerns before we telling you what will happen? No, doctor. All right. So it's very important to be admitted in the hospital to be treated. We already gave you oxygen, fluids, and antibiotic. All right. And we have taken some bloods from you to check the functions of your organs and the function of your lung and your urine output as well. All right. And then we will keep monitoring you. We will keep giving you the fluids, and then based on the case, if the patient has wound or any surgery or anything, it's based on the case. Okay. This is in terms of sepsis. Saying lactate culture and urine output, fluid chart and urine output, and serial lactate and all of these, you should mention them to the examiner if you are talking to the examiner at the 6-minute bill. All right, using SBAR. All right, so this is in terms of sepsis fever. Okay. Any question? Any question? Someone wanted to ask something.
Yes, Dr. Rosa. In my exam, I am a repeater, as you know. In my last exam, I started to talk to the examiner after I finished my station. I finished everything. Then I summarized everything I've done. Then so I started to talk to him. He did not respond to anything from what I told. Actually, I don't know if this is right or wrong.
Was your task to talk to the examiner?
Nothing was written. I had the same man. I did everything like that. Then I started to tell him what I did. Everything I have done, I told again. I summarized the case.
Okay, you don't need to do that. If it's not your task, if
Yeah.
it's not written in the task, talk to the examiner, then you don't talk to the examiner.
He did not respond to me really. Yes.
So yeah, so it was not your task. Yeah.
Yeah.
Okay. All right. If someone has anaphylaxis, in which part I give adrenaline once you suspect anaphylaxis? Sometimes in A. All right. It's a life-saving. Okay. It's a life-saving. All right. Once you suspect. Yeah.
Another question, please.
Tongue edema, lip edema with hypotension. This is definitely anaphylaxis. Give adrenaline right away. Okay, if there is no tongue edema or lip edema, you can wait to check. If there is any wheezes, any rash in the chest with hypotension, then you can give it. It's based on what, you know, what's in the station, all right? Once you suspect, you give adrenaline, either in A or B. Did I answer your question, Dr. Am?
Yes, doctor, thank you.
All right. Okay. Okay. Yeah, so we can take another case. So the patient is presenting with weight loss. Yeah. So what are the red flags that you think about in any weight loss?
Constitutional symptom.
Cancer, right?
Yeah, cancer. Yeah.
Cancer. And the other differential that you can think about is hyperthyroidism, maybe?
Yes. Yeah.
Okay. But your red flag is cancer, okay? So you explore the weight loss. Since when you have been having this weight loss? How much for how long? Is it intentional or not? These are the questions for any weight loss, okay? Then GIT symptoms, if he says, you know, I do have something else in my abdomen, all right? But weight loss, then you ask about tiredness and constitutional symptoms that you said, like you said, or cancer symptoms, fever, loss of weight, appetite, no, fever, lumps or bumps, appetite, weight loss, the patient has already weight loss, and night sweats, okay? You don't need to ask all of them. You can ask about tiredness and appetite and lumps and bumps, and that's it, all right? Usually it is present, the patient has cancer, okay? Yeah. So cancer symptoms, it could be cancer anywhere in the body, okay? He might tell you, I have some tenderness in my abdomen, then you can ask about the GIT symptoms, all right? If he doesn't say anything, you can think about blood malignancy maybe. So easily bruising, bleeding tendency, okay? Recurrent infections, you can ask about these. Then you move on right away to past medical history. Did that happen before? Any medical conditions? Any family history? Family history of cancer, okay?
Yes.
You can ask about smoking and alcohol, all right? If you have, if you feel like you are controlling the time. If no, you can just postpone them in the management, based on what you feel. Okay? Um, if the patient tells you, I have pain in the upper part of my abdomen, or right part of my abdomen, or tenderness, then you think of liver affection. Then you can ask about alcohol. Maybe the patient is drinking alcohol or having excessive drinking. Yeah. If he says yes, how much for how long? It's based on that case. All right. This is general outline for the case. The positives could be different. All right. So exploration of the weight loss. Ask about the other symptoms of cancer. Think about blood malignancy. Did that happen before? Any medical conditions? Any family history? Allergy is not important. Okay. Then smoking and alcohol, if you suspect or if he tells you something related to the abdomen. Okay. All right. Then you can ask about, if you don't have time to ask about smoking and alcohol, you can bring them in the management. All right. It's based on what you feel. Okay. You can ask him in the psychosocial, how have you been affected by this? You asked me about my mood, which is okay. All right. Do you have any concerns? Ideas, concerns, expectations. But usually in examination cases, please, in examination cases, you ask concerns only. Don't waste your time on asking ideas, expectations, and these things. What's your main concern? Okay. Then you move on to the examination, check the observation as you did, then explain to the patient. You didn't explain to me.
Why I explain?
You explained to me what is the exposure and from where to where exactly.
I said I will expose your abdomen from
Okay.
down to from above the abdomen.
Yeah, from the mid chest or from the nipples or to the mid thigh. Okay. I will have a look and listen and tap on your abdomen.
Yeah, I told.
You
Yeah,
did. Okay. And provide a chaperone with me
I
and
have a
check it
chaperone.
and
Yeah.
so.
I
Okay,
said,
you did that. All right. Then you inspect. You don't need to say what are you inspecting. In my videos, I just verbalize what I'm doing just for you to learn what you are going to watch for if the examiners asks you. Okay? Usually you inspect without talking. Okay? Then you palpate. When you palpate, you tell the patient, I will have a light feel on your abdomen, and I will press deeply. Okay? You have a problem, Dr. Iman, in just saying the simple words. You are saying medical jargons. Okay? So I will have a light feel on your abdomen or on your tummy, and then I will press deeply. Okay? In the examination, you should be able to, let's say this is the abdomen, this is the head, and this is the leg here. Okay?
yeah.
So this is right and this is left. This is right and this is left. Okay? So you should be able to examine
Divide. Yeah.
the quadrants, the 9 quadrants. Okay? So you start in a zigzag shape from here, then here, and then here. Okay? In a zigzag manner. Okay? Either from the lower left or from the lower right, whatever you want, but in a zigzag manner. Okay? I will start from the right, left, so I will have a light feel on your abdomen. Okay? Looking for any tenderness. Okay? Tender here in the right part. Okay? this is the right. Let's say this is the left and this is the right. Okay, so the liver is here. Okay, so then the patient might tell you, doctor, oh, it's tender here, so there is tenderness here. Okay, shall I move on to the deep palpation if there is tenderness or no?
Yes.
Yes. Okay, I don't move to the deep palpation if there is any guarding or rigidity, but here there is localized tenderness. Then you tell him, okay, I'll press a little bit deeply, okay, to check any masses first. So deep palpation in the 9 quadrants again for masses, and then the liver span. Can you please take a deep breath and then check for the liver surface and border. Okay? You can feel that, and you will feel liver enlargement with irregular or hard you know, the consistency of the liver is hard and irregular. Okay? Spleen, okay, from here, and you move on to check the border of the spleen. Okay? This is the deep palpation, the kidneys. Okay? After that, the tapping. I will tap on your tummy. Okay? You go U-shaped. This is a U-shape. You go from the umbilicus downwards, and from umbilicus to the left, and from umbilicus to the right. And then once you feel dullness, you
Ask the patient.
sorry, resonant, then dullness. Then you stop here and ask the patient to move on to the
To rule
side.
to rule.
Okay, this is how to show that you are doing the steps. Okay, I felt that you were not doing the steps correctly, Dr. Iman. Okay,
Yes.
so you have to show the examiner that I am doing the steps correctly. All right. Okay, then the percussion, we've talked about it, and auscultation, you listen to the intestinal sounds. I will have a listen to your abdomen or your tummy, okay, to check your bowel sounds. Yeah, then I will complete my examination by checking the glands in the lower limbs and, you know, perirectal examination. Yeah. Then your management. You should be able to do abdominal examination in 4 minutes. And it's doable by practicing. Okay? It's doable by practicing. All right? In diagnosis, you tell him, we have found your liver is enlarged with the symptoms that you have. It could be immunological problem. It could be something more serious in a sensitive way, like cancer level. Okay, if there is no lymph node enlargement, no signs of blood affection, you know, cancer of blood, you can say, you know, liver cancer. Okay, if there is lymph node enlargement, usually the generalized lymph node enlargement, the patient might be having lymphoma or leukemia, and then the liver is enlarged because of that. Okay, or there is something else, cancer in anywhere else, and it's a metastasis. Okay, but if the patient has only hepatomegaly with tenderness, weight loss, no lymph nodes, the patient is drinking alcohol maybe, or having a family history of liver cancer, then you can just say it could be, you know, cancer in your liver, and give a pause to the patient. I know it's overwhelming. We didn't confirm anything yet. We will need to do more investigations. What are the investigations that you need to do? For blood count or liver function tests and all the markers, the hepatitis markers, the serology, for all of the assessments, and refer the patient urgently within 2 weeks to do ultrasound on the liver, and also they might do a CT scan on your liver as well. Okay. If you have time, you can talk. If you have time, you can talk about cutting down alcohol if he's drinking alcohol, cutting down smoking if he's a smoker. This is if you have time. All right. It's one of the easy cases, to be honest. All right. It's just about how to manage your time and how to do the steps correctly, confidently, with the time management. All right. Any question in this case? In pediatric basic life support, you are talking to a medical student or a colleague wants to learn how to do the basic life support on a child. And usually in the question, they mention the age of the child. Teach the student or teach your colleague pediatric basic life support on a child who is collapsed in the hospital or in the street. They don't mention anything, and not in the hospital, not in the street. You have to be able to read your question carefully, okay? The child usually is 9 years old or 6 years old, above 1 year, okay? You should be able to know what they want from you exactly. Is it basic life support in the hospital or basic life support in the street? Okay? If they don't mention anything in the question, you should be able to ask the student or the colleague, what do you want to know exactly? All right, a patient collapsed on the street or in the hospital. If he tells you both of them, then you talk in general. All right. What is the difference of basic life support in the hospital and the street? Any idea?
So
Any
in the
idea?
in the hospital, I believe they have AED and they have nebula. They have o- oral tube and nasal-oral tube, something like this.
All right. Okay. So the main difference is in your call. Okay? Your call for help. If the patient is in the street, you call the ambulance, the emergency services, 999. Okay? For the ambulance to come with the automated defibrillator. Okay? In the hospital, you call the resuscitation team. Okay, you call 2222. This is the line for resuscitation team in the hospitals. 2222. You call them. You tell them we need the pediatric resuscitation team. You have to tell them who is the patient, adult or pediatric. So they provide you with the correct team. Okay. And you tell them where you are exactly, okay? In which department, which ward, what is the bed, all right? So this is the difference between a hospital and a street, okay? All right, let's say that we have a child here. Okay, this cheeky monkey, he is collapsed, and you are teaching your student or your colleague on basic life support. Okay, the principles of teaching of basic life support in adult and children are the same with few differences. What are these differences? The differences are in the head position, especially in infants, okay? On the rescue breath, Okay, so if you take them from up downwards on the head, on the mouth and nose, the mask, and then the cardiac massage itself. Okay, these are the differences. Firstly, if the child is infant, or if the patient is infant, less than 1 year, you don't need to do head tilt chin lift. Okay, you don't need to do head tilt chin lift. All right, you just put the patient, the infant in the neutral position, just slight raise of the chin, just like this. Okay, that's it. All right, this is the first thing. Secondly, rescue breaths. We don't usually give 5 rescue breaths in adults. All right, and we start our CPR in children by 5 rescue breaths. Why? Why is that? Why? Because we in children, usually they don't have heart conditions unless they have congenital heart diseases, but this is not common. All right, the commonest cause of arrest in children is coming from the lungs, from the respiration. All right, that's why we start with 5 rescue breaths first. Okay, you give 5 rescue breaths. In most of the children, once you give them 5 rescue breaths, they come to life. Okay, this is the second difference. The third difference is in the cardiac massage itself. All right, the cardiac massage, the ratio of chest compression to breath in adult is 30 to 2. Okay, in children it's 15 to 2. 15 chest compressions to 2 breaths. All right, this is the first thing. The depth of compression, in infants less than 1 year, you compress the chest in a depth of 4 centimeters. Okay, maximum 4 centimeters. Children above 1 year, the depth is 5 centimeters. In adults, the depth is 6 centimeters. So 4, 5, 6. 4 for infants, 5 for children, and 6 for adults. This is the depth. Okay? How to do this chest compression? In adults, we just use 2 hands and compress. Okay? Right? No. In children, if we have infant less than 1 year, either we do 2 fingers technique. Okay? 2 fingers technique. The middle and index finger, 2 fingers technique, or encircling technique. You encircle the child and compress with your thumbs. Okay? This is if the patient is infant. If the patient is child above 1 year, you use 1 hand, the heel of your hand, the heel of your hand. This is the heel. Okay? You compress by 1 hand only. All right? You lock your shoulders and the movement comes from, you lock your elbows and the movement should come from your shoulders. Okay? All right? By the heels of your hands. Okay? You should be able to explain to the student how to do the chest compression. You should compress and wait until full recoil of the chest. Okay? It's not like this. No. 1, 2, 3, 4. Okay? You wait for full recoil and then compress again. All right? How to know the right place to put your hands? It should be with the, you know, the position of nipples. Okay? The chest bone. Okay? All right, doctors? So these are the differences in between the basic life support in children and adults. Until now, is everything clear? Clear, doctors?
Yes, clear. Yes.
Yes, clear, doctor.
Okay, good. So how to explain to your student or your colleague the basic life support? In the question, we have teaching basic life support on a child who is 6 years old. Okay? Let's say that this child is in the hospital. Okay? All right? So you greet your student or your colleague, make a rapport with him. How are you? How is everything? How is the day today? Is everything okay? I can see that you are in year 5 or 6. Like, is it busy today? How are your studies? Is everything okay? Are you enjoying some, you know, some rapport? Okay, and then I can see that you want to learn about basic life support in children. Is that right? Yes. Okay. What do you want to know exactly? What do you want? This is your data gathering. What do you want to know exactly? What's your background about basic life support in children? Okay, and why do you want to know that? These are the 3 questions in any teaching case. This is your data gathering, all right? Then you start by explaining to him. Well, okay, so we have the child here. The child is collapsed on the hospital corridor, okay? The child is not responding. You want how to know that, how to know that the patient is responsive or not? Okay, let's say the child is Alex. Alex, can you hear me? Alex, no response. Then you squeeze his shoulders. Okay, Alex, can you hear me? No response. Okay. And before that, just sorry, before that, you teach him. Okay, you teach him that you have to make sure that everything around you is safe before you reach Alex. Okay, so you tell him, well, we have Alex is here, he's collapsed. You make sure that everything is around you is safe. Then you approach Alex. Alex, can you hear me? No. Then you squeeze his shoulders. Alex, can you hear me? No, no response. Then you shout for help right away. You call 222. You tell them, okay, I have a child, I need the resuscitation team, the pediatric resuscitation team, please. We are in the pediatric department, bed number, blah, 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 blah. All right, then you come to Alex, okay? You do head tilt, chin left, okay? Like this, okay? You tilt his head, and then you move his chin above, upwards, okay? And then what are you going to do? You check for signs of breathing, all right? You look, listen, and feel. You look at the chest, okay? And listen to the breathing sounds and feel the carotid pulse. No signs of breathing, okay, then you right away start your basic life support. Once, what is the first thing that you do? 5 rescue breath. 5 rescue breath. It's not chest compression like adults. 5 rescue breath, all right? Okay. So do you have any problem? You tell the student, do you have any problem in doing head tilt chin left? Okay, you make sure that the student can do that. This is how you show your teaching skills. Okay, if he just do head tilt chin left in a wrong way, you correct him. Well, okay, no, you just try to put your hand here, okay, and tilt his head back, and then you lift his chin like this, okay? You correct the student, okay? Then the 5 rescue breath. You have the mask. You have to put the mask fitting to the nose and mouth, okay? How to hold the mask? We have CE way. Your hands, your thumb and index finger making C on C letter on the mask, and the other 3 fingers are on the jaw, supporting the jaw. Okay? Can you see that, doctors? Okay? C, E. C on the mask and E on the jaw. Okay, doctors? Clear?
Yes, clear.
All right. Okay. Then you give 5 rescue breaths. 1, and check the chest is going upwards. 2, 3, 4, 5. Okay. Can you do that, please, for me? And then ask him to do. All right. You can ask the student once, either head tilt, chin left, or the mask. Okay. Or the chest compression, whatever you want. But always show your teaching skills, okay? All right, you give the 5 rescue breaths, then you start your cardiac massage, okay? How to provide or how to give the cardiac massage? By one hand, the child is 6 years old, so by one hand, the heel of your hand, you put it align with the nipples of the child, and then with the heel of your hand, your elbow is locked, the movement's coming from your shoulder, and you compress 1, 2, 3, 4, and make sure that there is full recoil of the chest in a depth of 5 centimeters, in a rate of 100 to 120 per minute, in a ratio of 15 chest compression and 2 breaths. Okay, you continue doing that until signs of life come back, or you're exhausted, or the team come to you. All right?
Sorry, Dr. Can you say it
Yeah.
again? The rate?
All right, depth 5 centimeter, rate 100 to 120 per minute, ratio 15 chest compressions to 2 breaths, 15 to 2.
Okay, thank you.
All right.
Yeah,
Let's say that the patient is infant. Okay. How to check that the child or the baby is responding? Any idea?
by breathing, movement test.
Again?
Either coughing or I see movement. There is
No.
movement.
The child is arrested. How to check if he's arrested or responding? Is he doing any response to you or not? In the children and adult, we say, hello, I'm Dr. blah, 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 Alex, can you hear me? No, then squeeze. Okay? In infants, you say, you do like this. Alex, and try to tickle his heels. Okay?
Okay.
If no response, then you call for help right away, and then you come back to give the rescue breath and the sequence of steps. All right? Any
Yes.
question? Any question, doctors? So this is regarding basic life support in pediatrics.